Muy buenos días a todos y bienvenidos a otra sesión de El Doctor on Call on the Parking Lot. Bienvenidos a la sesión del médico de guardia en el parqueo. Hoy quiero hablarles brevemente sobre cirugía, el tema de dolor abdominal causado por enfermedades biliares. Es un tema que frecuentemente se presenta en los boards, cómo debemos hacer los diagnósticos diferenciales, bien rapidito, y qué es lo que normalmente se hace. Okay, so let's go straight forward. This is a 54 years old female, moderately obese, that comes to the emergency room with a pain in right upper quadrant. Right there, you stop, and we go to the end of the question, and we're trying to figure out what is that they want. And the question again goes with, what is the next step? And in the choices, we are going to look, for example, the abdomen ultrasound. We're going to see ERCP. We're going to see percutaneous transhepatic cholangiogram. We're going to see open abdomen and exploratory of the biliary region, or it can be removing the gallbladder via laparoscopy. So from all these, we already know that this is a question for management. And then we go back to the question and we start reviewing the whole thing again. So now we can focus what is the management according to a particular stage in the development of a condition. Now we go back, we know it's a person with right upper quadrant. Now we find out that the person has jaundice, that the person is complaining with this relatively moderate pain. The jaundice started approximately 2 days ago, is getting worse now. The person has a moderate fever, 102 degrees. She also has the, when we do the diagnosis, the laboratory work, we find the white blood cells moderately increased to 15,000. We find the alkaline phosphatase increased to 300, and we see that the direct bilirubin is 8, and the total bilirubin is 13. By the way, the direct bilirubin is the conjugated bilirubin. It's the bilirubin that has been associated already, and therefore this is the one that we can measure. So therefore, whenever we have direct bilirubin, we are not going to be thinking in this process in the question. We're just trying to focus into answering the question of the management. But for the educational purpose, we have to differentiate. Immediately, whenever we say direct bilirubin, immediately think obstructive jaundice. Immediately. So we don't have to even think if it is conjugated or not inconjugated. We think direct is conjugated, period. Then, boom, we already go next association, direct, conjugated, obstructive. Now, when we go from these practical terms, we also realize that the patient now is complaining with the feces getting relatively white or pale. The urine is yellow, and the exploration obviously gives us a Murphy sign positive, and all the actually is a pain in the epigastric pain, just fixed there, doesn't radiate actually. So with this information, the next step, what would be the next step? We identify the case as obviously a biliary tree disease, and everywhere that we have a biliary tree disease, the next step for the purpose of diagnosis and the gold standard is called ultrasound. So we forget about the other things, just go immediately do the ultrasound. Now, the patient is found in the ultrasound. They give you the next question. The patient is found that actually have a common bile duct dilated to 0.9 centimeters, 9 millimeters. Okay, so with this information, and then they say that there are multiple stones in the gallbladder, as well as impacted in the common biliary duct. So with this information, you can say, well, the patient may have cholangitis and may have ascending cholangitis, basically because of the symptom of jaundice, pain, and fever. Now, by the way, how do we call this? Do we call this the Charcot triad? Jaundice, pain, fever, right upper quadrant pain. This is a Charcot triad described for the ascending cholangitis, a major emergency. So we have to actually take the next step. Usually, the next step, they are asking you what is, you are admitting the patient, and during the admission, the nurse calls the physician to tell them the person has dropped is complaining with more pain and has dropped the urine output for 45 cc's to 15 cc's, and the fever is getting worse. The white blood cells, they were ordered again, increases to 25,000. Also, the bilirubin, the direct bilirubin is also increasing, the total bilirubin increasing. Alkaline phosphatase is like emergency. Sometimes we did too much laboratory work. In many places, we just simply go directly and do the procedure. In this case, there was a lapse between, because remember, many hospitals do not have the physicians right there. In the United States, the physician is in their consult, and then it takes usually some time to for the patient to be actually seen by the surgeon. So for the purpose of the standards, what is the next standard? What is the next step? The next step, they ask you, for example, if it is going to be an ERCP or endoscopic retrograde cholangiopancreatography, or if it's going to be a percutaneous transhepatic angiography, cholangiography, or if it's going to be a laparoscopy removal, or if it is going to be an open removal. All of those conditions are really have a high mortality and a very high incidence of complication. In this case, the critical scenario is that suddenly the blood pressure drops. The pressure go under 85 cc's mercury, and the pressure is started to develop the altered mental status. It started to be confused, and it started to speak a slurred speech. So right there in verbal response, in the Glasgow scale that we saw, the person is dropping to a scale of 2 in the verbal response. And the motor response is also decreasing the motor response. So there, with these features of altered mental status and the decrease in the blood pressure, we have a critical new scenario, which is called renal pain-taid. Instead of being the Charcot triad, the fever, the upper right quadrant pain, and the jaundice, now we have the Charcot pain-taid plus the decrease in the blood pressure under 90 millimeters of mercury, and the altered mental status. Those features again are high mortality, high serious problem. Now, what is the treatment? For the purpose of the treatment, we already differentiate what is the diagnosis. The diagnosis, we already know there is a stone, and according to the location of stone, we can say the diagnosis. We have one stone impacting the common bile duct, that is cholangitis. Acute ascending cholangitis is producing an obstruction of the flux of the bilis and is creating a jaundice. Another possible complication will be gallstone pancreatitis. But if the ultrasound doesn't give us that the person has any stone in the pancreas duct, so right there, that is not a diagnosis. It can be confusing because the pain can be very similar, but in the gallstone pancreatitis, the pain is more like in a bar instead of being fixed in the epigastric region, and it usually does not have jaundice. Now, the cholangitis is basically the presence of these stones in the gallbladder. and they can basically the treatment is totally different. The treatment for the cholangitis, we can have more time, and we can put the antibiotics, we can get the person into the intensive care unit, and we can observe and eventually remove with laparoscopy the gallbladder without that much stress. But in this case, it's acute evidence of obstruction. Alkaline phosphatase is very indicative of this acute obstruction, or this serious obstruction, should I say. Now, the treatment against would be what is best, ERCP or percutaneous transhepatic cholangiogram. The two are actually again very high mortality, but in this case we select the best choice is percutaneous transhepatic cholangiogram. So we go there and insert a needle. Usually there is more than 90-95% success for the ERCP, for example. This is also the standard now, since basically everywhere we does these procedures, and then insert the needle, release all the pressure, including the pus or the bile acid coming through relieving the obstruction of the after removing the stone. So this is in general how this is managed, and this is a very simple scenario. Now we're going to be seeing scenarios of the other common diseases in the abdomen that are associated with pain. Because we don't have too much time to load, I'm going to divide this in several sessions to make it simpler for you to watch. So this is all for now. Thank you very much. Thank you for watching the Doctor on Call at the parking lot, and come here back soon. Thank you.